Good afternoon, everyone. So today I'll be presenting a free paper titled IOL Formula Calculation in Pediatric Eyes. Do we have an answer? No financial disclosures. Pediatric cataract surgery with intraocular lens implantation is a very commonly performed procedure worldwide. But in children, there are some challenges in the IOL power calculation. Some of them are the axial eyeball growth and the tendency for myopic shift, because of which we need to do a targeted hyperopic undercorrection, poor cooperation for measurement in children, and so the measurements are usually done under general anesthesia, where fixation and centration is usually a problem. And also, the commonly used IOL power calculation formulae are validated only in adult eyes. So the aim of our study was to assess the predictability of SRK2 and Barrett's universal 2 formula and the possible effect of axial length, keratometry, and age. It was a retrospective study. Total of 123 records were analyzed and 72 eyes of 39 patients were included. Children under 8 years of age who underwent cataract surgery with IOL implantation were included, but children who also had other ocular anomalies or other ocular disorders were excluded. So the IOL power was calculated according to SRK2 using the age-appropriate target hyperopic undercorrection given by NAD et al. And after the surgery at post-op 1 month, the refraction was done and the spherical equivalent was calculated. So the prediction error according to SRK2 was calculated as the difference between this post-op spherical equivalent and the target refraction. Then the IOL power was calculated according to Barrett's using the same target refraction, and the post-op spherical equivalent was back calculated. So the prediction error according to Barrett's was the back calculated spherical equivalent minus the target refraction. So mean prediction error and mean absolute prediction error when both the groups were compared, and further subgroup analysis was done for axial length, keratometry, and age. The statistical analysis was performed using SPSS version 21, and the difference in the predicted error and absolute predicted error between the two formulae was analyzed by Wilcoxon sign rank test. P-value of less than 0.05 was considered statistically significant. So coming to the results, total of 72 eyes of 39 patients were included. The mean age of surgery was around 3.8 years. In the overall cohort, we can see that the mean predictive error for Barrett's was much lesser compared to SRK2, and this value was statistically significant. But there was no major difference between the mean absolute predictive error in the two groups. Further, according to subgroup analysis, according to axial length, the cohort was divided into 3 groups. In the 18 to 21 mm axial length group, SRK2 performed much better than Barrett's, but in the 21 to 24 mm group, Barrett's had a much lesser predictive and an absolute predictive error compared to SRK2. But in the higher axial lengths, both these IOL formulae gave a higher predictive error. In the correlation analysis, a strong positive correlation was seen with the predictive error using the SRK2 for the higher axial lengths. So the subgroup analysis was then done according to keratometry. It was divided into 2 groups. In the group which had less than or equal to 45 diopters keratometry, Barrett's had a much better predictive error compared to SRK2, but in the higher, steeper corneas, both of them were almost comparable. And there was a significant negative correlation in the overall keratometry group using Barrett's. Subgroup analysis was then done according to age, and it was divided into 3 groups. In these 3 groups, overall Barrett performed much better compared to SRK2, and the least predictive error was seen in the less than or equal to 2 years age group, and after that in the beyond 5 years age group. No significant correlation was found for this. So in our study, overall, Barrett's had a lower mean predictive error as compared to SRK2, and this value was statistically significant, but the mean absolute predictive error was similar in both. With respect to axial length, in the 18 to 21 mm, SRK2 performed better. In the 21 to 24 mm, Barrett's performed better, but in the higher axial length group, both had an equal predictive error. For the steeper corneas, SRK2 and Barrett's were comparable, but in the flatter corneas, Barrett's had more predictable outcomes. And Barrett's had a smaller prediction error across all the subgroups of age, especially less than 2 years. So when we compared our study with other similar studies that have been done, we can see that there's no single IOL power calculation formula that has been given by any study. Chang et al. Said that Barrett's performed actually better in the higher axial lengths and in children more than 2 years of age. Epley et al. Said Barrett's performed equally well in across all the age groups, all the axial lengths and all keratometries. But Kekunaya et al. Actually found that SRK2 had the least predictive error across all the groups. So in conclusion, from our study, we can say that Barrett's can be used with predictable outcomes in children less than 2 years of age and above 5 years, eyes with axial length between 21 to 24 mm, and flatter corneas less than 45 diopters. Thank you.
No.